Director of Substance Misuse and Behavioral Health. The primary purpose, according to the legislation and the grant, is to coordinate state resources, work with state agencies and community partners, identify barriers to treatment, identify care gaps, work to formulate a seamless continuum of care, much of which Mr. Susi referenced, recommend changes in policy that could mean changes in law, and that's just a general thing. So as I move towards developing the 22 recommendations, they basically flowed from the multiple years worth of work that the Governor's Commission did on alcohol and drug abuse, and they came out with about a 90-page strategic plan. From the 90-page strategic plan, I developed these 22 action items that we're trying to be consistent with now. So I can walk through those 22 points very quickly and then ask questions, answer questions, or whatever you want to do. You've asked a lot of questions. I've taken some notes. Some of them are connected. Many of them are companion to the efforts that I'll be undertaking.
If you go through the 22 steps.
Okay. I have 3 general categories that I'm focusing in on: prevention, treatment, and recovery. We're going to increase Narcan availability. Obviously, as you know, the statute was passed that makes that available to third parties. As simple as that language was, there are issues with respect to Board of Nursing, Board of Medicine, Board of Dentistry, Board of Pharmacy, and what's called the Collective Practice Act needs to be ironed out, and we're very close to concluding that to make this available. The state of New Hampshire is working to use some funds to actually get into a group purchase arrangement to make Narcan more available from a financial burden point of view to those people who are using it at great excess. As we know, Narcan is not a panacea. There are ups and downs to it depending upon where you are, but the legislature has been passed. It will offer some benefit to some people, and we'll implement that as soon as practical. Obviously, much of what I'm doing will come to life if there's an expansion of Medicaid. We already had that discussion. I have visited with 13 treatment providers from around the country, some of whom operate in the state, some of whom do not. I have had discussions about them to come into the state and provide treatment. Remember, aside from Medicaid, there are still 2 ways to pay for treatment. You can pay for it, and there's private insurance. Medicaid, depending upon however that rolls out, is obviously additive to that structure, but we can respond and increase treatment and begin to tackle this regardless of what Medicaid does. It will be very helpful, but we still have private insurance and we still have people with cash. People come to me and they've had to send their family members across the country. So we can increase treatment here, keep that money here, and make it easier for our citizens to access treatment. And with that, what I wanted to do in my plan is to establish about 10 detoxes around the state with intensive outpatient treatment to begin to break up that logjam so that when there's an overdose, there's an opportunity to get them detoxed. We're considering passing or introducing legislation that might make several days of treatment mandatory in an effort to get somebody undercover and perhaps have an opportunity to introduce them to treatment. That is legislation you might see in this next round. So I'm working on that. We certainly, I'll be working with the New Hampshire Hospital Association and other providers to shepherd the expansion of treatment. If they don't do it directly, I'm working on a plan to allow that to be subcontracted within under their roof to help them be responsive to it. It is not easy necessarily to have all the skills in all hospitals with respect to substance abuse treatment and withdrawal management and that sort of thing. So we may need to corral some services for them. We're obviously having a statewide discussion about expanding drug courts. You know that rough and tumble in terms of funding as well as anybody. As recently as this afternoon, I was talking with the governor about continuing efforts to try to identify a source of funds or a way to get some funds so that Manchester could have a drug court. We will be, as a result of the prescription drug monitoring program, the changes that were made to that, which went live on July 22nd, we'll have a broader ability to share prescribing patterns across state lines, as well as to heighten the ability of the Board of Pharmacy and the Board of Medicine to keep track of the physicians and their prescribing habits, and to do whatever they need to do to bring that in. Consistent with that, I've been working with several hospitals in this city, and I expect that we'll be announcing the state's first consolidated prescription opioid scope of pain conference for physicians and practitioners. I think that'll probably happen in November. Catholic Medical Center has been working with me, and Tim's had conversations with them as well as the mayor. That will be open to any facility, any prescriber, any doctor, and we hope to either fill the Radisson or the Grapponi Center. We have funding for it all the way through. It isn't going to cost anybody anything, and that program is in the box, ready to go. The promotional materials are ready to go. We need to nail down the date, and then I expect that we'll see that launched very, very soon. My goal is to move that program around the state so that we get every single prescriber, and there are 12,000 of them, versed on scope of pain practice, opioid prescribing, so that we can reverse this endless flow of opioids which are flooding the market. That's a big goal. I see no way around it. We have to do that education. I have been working with the New Hampshire Providers Association on parity compliance. Parity, as you may know, is the newly hatched a series of regulations which require that substance abuse treatment be provided by insurance companies to the same extent that other diseases within the policy language is provided. So I have been working with family members and providers, and I'll be meeting with the chief executives of the insurance companies to let them know that parity compliance is something we'll begin to track. I've worked with the Department of Insurance to begin to track insurance denials. Or at the moment, we do not track denials of coverage. We will start to do that when the rules process is completed. And so my hope is that we'll see coverage come up and denials go down. And we will track each and every denial, and the insurance department will be able to drill down and determine if the insurance companies are complying with the law. So that will go a long way towards improving people's access to treatment once we create that treatment. I met this morning with Commissioner Berry of the Department of Education. We had a long talk about my vision that the prevention efforts that are taking place now. Manchester does a great job. They have a wonderful array of prevention efforts in the schools. But my conversation with her involved prevention messaging being integrated into the curriculum, which is a little different theory, but what it does is it expands really the army of people sensitive to substance use disorders, aware of it, and partners in it, and that would be teachers and basically anybody within the school. And that's a little different than I'll say the outer circle of prevention, where you've got your school resource officers, your counselors, and that sort of thing. I want to get it more integrated into the curriculum. There are models around the world, literally, different ways, but as you can imagine, this was going to be a very significant coordination effort, because home rule means that obviously every school board gets to decide the fabric of the curriculum that they have. There are minimum standards already issued by the Department of Education with respect to what has to be in a curriculum. There is a wide latitude of response to the minimum criteria. My goal will be to identify those schools that have very good programs and to fire up those people so that the best practices can be spread around to other schools around the state. I'll be meeting with the Superintendents Association in October. There's a principals group that I'll be meeting with, and there's many groups to this. The New Hampshire School Administrators Association. So we'll be firing people up to get behind this so that all the prevention efforts can become more integrated and more uniform to the extent that that's possible across the state. While Manchester does a very good job with prevention, some schools don't. And we need to carry that message across the state to the next generation of kids. And for my money, it is as far down as kindergarten. The moment the kids leave the house to go to a setting where they're together with other kids, prevention messaging needs to start. But that takes an army of people, and they're called teachers and counselors and all the rest. So that is going to be a big initiative. The Department of Education is primed and ready to go, and they'll be continuing to make connections so that we can have that discussion and keep it moving. Vivitrol, you mentioned Vivitrol. I talked to an entity from Manchester who was interested in a Vivitrol trial program, and I imagine when I hear from them, they came up to me after the forum that you all had here the other day. I'll probably reach out perhaps to Mr. Susi and coordinate that a little bit. That's very useful. It is absolutely essential, though, that Vivitrol be in combination with an intensive outpatient program, because it is not a panacea drug. It has to happen with an intensive level of therapy. So it takes the right team members with the right intensity for the right duration for it to maximize its effectiveness. We are working on that. We're working on the Department of Corrections to also do a pilot program for those people being released from prison. Again, they have to be released into an intensive outpatient program in order for the medication to have its maximum effect. So I think you'll see those two pilot programs roll out. I'll be meeting with New Hampshire 211 to see about their ability to create an addiction hotline, which will, as the continuum of care structure that Mr. Susi referenced takes shape, we'll be able to have, I hope, a single call across the state which will refer a caller to a local resource. In my view, it'll be a healthcare facility that is capable and trained to do a uniform, standardized assessment of their addiction and the treatment that they need. This would flow from ASAM criteria, the American Society of Addiction Medicine, so that no matter where you are in the state and how you come to the attention of healthcare, you'll get a standardized assessment which will determine the sort of care you need. And when you have that, it will make it easier then to correlate that to insurance coverage decisions, because one of the things I hear is it takes a while to get decisions from insurance carriers, there's a lot of back and forth, and then you miss that opportunity to introduce somebody to treatment when they otherwise might be ready. So those efforts will continue to coordinate so this will begin to come together. Recovery is profoundly important. I am working with the Bureau of Drug and Alcohol Services. Again, Tim mentioned that there were a number of recovery coaches that have been trained using grant funds. In Vermont, when they established 12 recovery centers around the state, ER visits for drugs and alcohol dropped on the order of 80%. So, and that's just one. There's a number of statistics I'll be publishing with respect to the success that recovery communities have. It is a profound safety net. Once somebody comes to want treatment and gets treatment, to keep them straight and sober and to help them return. It takes over a year for the brain to recover from heroin, so they need those ongoing supports. I'm in the process of hatching a plan to try to raise funding for that, because, as you can imagine, it is unlikely the government will fund that, but I think that's fundamentally essential for us to break the cycle that we're in. I have serious concerns, and I realize that methadone clinics and pain clinics are rather highly regulated. I have some concerns about, as an abstinence base, I come from a background of treatment spanning 40 years, expecting that the brain was intended to be abstinent, and I think it could be. And so I'm troubled when I see people on methadone too long. Obviously, clinical people differ about that, but I'm very concerned that the methadone clinics be focused on getting people abstinent-free over some period of time. Pain clinics, I have trouble with pain clinics. I want to see a pain intervention team within healthcare, which is interdisciplinary. This concept in my head of treating somebody at a pain clinic on the edge of town is simply unseemly, and I don't have a lot of tolerance for it. I realize that at the moment we have to do some of the things we have to do, but it's just distasteful. And so I'm going to do everything I can to work towards integrating pain management into Main Street medicine, I'll say, so that substance use disorders and addiction are no longer some sort of orphan disease that we shove to the edges of town, only to have those pain and the troubles and the burdens passed on to police and fire and EMS. Housing for people in recovery is also difficult. I have met with 3 groups already to encourage them to develop transitional housing for women. It is profoundly different than it is for men. I've also visited half a dozen facilities, sober housing for men. You know, men, you can put 10 or 20 guys in a building and they'll be fine. Women, you can't really have more than 5. You need to have private rooms, single rooms, allow for family integration, reconnecting with children, that sort of thing. It's a much different dynamic, and I have been reaching out to groups that I think might be able to support that, because again, we're relying on the generosity and the spirit of the community to make these things happen. More generally, I have begun conversations at the federal level to build a coordinated statewide telehealth network. There have been pilot programs scattered around. There's some aspect of telehealth and telemedicine. I think as we expand the treatment opportunities and we want to reach out to addicts in recovery in rural areas, particularly if they're participating in the drug court, we have to make the services available to them in the rural setting. And I mean, at the moment, that gets in the way of drug courts because you have to be close to it, ability to show up, ability to get an eyeball face-to-face and do other sorts of testing. There is a platform, there are platforms, there are numerous platforms for telemedicine and equipment and that sort of thing. That's a longer vision, but I think that as the demographics change and we expand treatment opportunities to rural New Hampshire, we have to get technology involved to allow us to have a stronger reach and a longer arm and better success. Suboxone, I have reached out to both the White House as well as Congressman Custer and Senator Shaheen on lifting the federal limit on Suboxone treatment so that more physicians can be certified in it and those physicians can treat more people with it. Right now there's a 100 patient limit as a matter of federal regulation. I will be reaching out to all the pharmacy chains. In my view, there needs to be medication drop boxes in every pharmacy. I understand the reasons as we sit here today why they're in police departments. I do not think that's the best place for them. I think it violates the circle of distribution. In my view, there's no reason why they can't be in every pharmacy going. Where you pick the drugs up is where you bring back your unused ones. That's going to take a little more work. There has been a clearance from a federal regulatory point of view that makes that easier. And I have so far had all of the major drug companies either on the phone or in the room to start a number of things, not the least of which was their responsiveness to Narcan and third parties. But the drop boxes will be the next topic. Questions?
Thanks. Jack, are there any, and maybe it's not fair to ask you this question right now, but maybe you can think about it for a day, based on the conversations you've had across the state, what you heard today from not only our department heads, the school district, and then the questions from some of the elected officials that are here, and a good majority of the Board of Aldermen is here. Are there some things that we can specifically do in Manchester to complement maybe the plan, make sure we're not creating duplication? We talked about that earlier. Again, it may not be fair to ask that question now, but maybe in the next day or two you could email the Board of Aldermen.
Oh, listen, I think that everything that you've talked about today, I haven't seen the detail of those points. Listen, this is going to be a cooperative and collaborative effort on everybody. And I don't have a single plan. My job is to help coordinate things in response to Alderman Long's question. Listen, I know there are people out there who are doing things. They're opening up sobriety centers, they're helping people, they're reaching out, and there's various faith-based operations that are helping. There is not enough. You know, I understand as we move towards the continuum of care and identify with particularity who's in the community and what they're doing, there's nowhere near enough. Even the ones we don't know about, there's nowhere near enough. And so we will develop those continuum of care projects. Those will be helpful as I continue my discussions with treatment providers on where to open up. I'm expecting they're going to apply a business model that between private insurance and private pay, they're going to look at the market, reach their own conclusions about where they think detox beds should be, where they think the inpatient, the intensive outpatient treatment should be. And it's their business model. It is not my business model. But nonetheless, the continuum of care positions are very important for all the reasons that you've identified. And all of the efforts in education will not be duplicative, I can assure you. We have a ton of schools. The more good projects that I can identify, the more good things that I can encourage you to do, then I can take those good projects and try to convince 200 to 300 other schools to do the same thing. There's no question that some schools, some school districts need help in getting fired up about prevention messaging and how we raise our kids. In many, many ways, Mitch, you're so unique with the energy and the resources that you have, but you are unique in that regard. And so all of the projects and all of the efforts that you can undertake, I'll be pleased to learn of, I will be pleased to echo, and I'll be pleased to offer to anybody else who will accept those successes.
Thank you.
Thank you, Mr. Chair, Mr. Wozmak, Keith Hirschman. As our community's been victimized by addiction, we as a board have strengthened our police department and our resolve to fight on an enforcement level. And I think we're committed to staying hard as a police force enforcement. My question is, once we get these people into county jail, whether it be for a day or 10 days or a month, is there someone in corrections that's identifying who's an addict? What are they doing once they identify in corrections? You can't correct somebody if they're an addict and you don't do anything. They're letting these people back out on the street. Are they being identified? Are they being treated? Are they being counseled? What's happening?
Well, I can't speak to all county jails, but I can say that I'll bet there's at least half of them that the answer to all of your questions is yes. From my history in county government, going back 18 years, we always knew who had a problem. We all did an assessment on them. Many of them were introduced to treatment while they were incarcerated. Many of them had treatment refined while they were incarcerated. And we have many jails have AA and NA and other groups, volunteers going in to provide treatment to those people. In a way, I'll say it isn't altruistic, because to the extent that you can identify these people in the jail, treat them while they're in there, and help them stabilize their behavior, they're better inmates. I mean, at the end of the day, the jail's responsibility is to stabilize the population while they're in jail. Now, county jails statistically, they're only there on average 20 or 30 days. And so the opportunity is relatively limited for, I'll say, a meaningful intervention. We have, there are some jails that will send you out if you come in and you're diagnosed and there's something that you can be treated with, which will help. Let's say you have a co-occurring disorder or mental illness, and we diagnose you in the jail diagnose you. They do make arrangements through discharge planning to try to transition you back out into the community. Obviously, once the jail is done with you, they have no legal authority to continue, right, that shepherding process. But most jails, I'll say, go through some effort to identify those people with problems. Again, the issue is transitioning back into the community with follow-up treatment and capacity to provide that treatment, as well as the money to pay for it.
Just follow up. So your message to corrections is that's one of your bullet points that you're going to follow up on.
Well, I would certainly like to see a more
It's in your
robust.
plan.
Yes.
Thank you.
Yeah, I would like to see the county corrections embrace Vivitrol as well, where a person in county jail, if they're sentenced there for less than a year, can be discharged to a program that can continue to offer intensive outpatient treatment. Because you're discharging as many people from county jails as you are in prison, fundamentally.
Thank you.